Hello, everyone. Good evening, good morning, depending on where you are joining me from. My name is Dr. Wisdom, and this is part 3 of optic nerve head assessment in glaucoma patients. So, I'm sure you've watched part 1 and part 2 because this is the part 3 and it's a continuation of what we've been discussing earlier. So, please ensure you subscribe, like, and comment on the YouTube channel so that you can always get notifications on what I'm doing and where we are going to. So this is the last part of what we are doing, and I'm sure to dot all the I's and cross all the T's. So today we are looking at optic nerve head key parameters in OCT. If you followed part 1, part 2, we've talked about the ophthalmoscopic assessment, and in part 3 now we want to focus more on OCT in optic nerve head assessment. So the parameters are based on the patient's age and disc size. Remember, in OCT we want to compare not just what we are seeing, but we also want to compare the patient's data compared to his age. So it is a comparative test in the sense that the machine also has imputed data on whatever your age grade has. So if you are 50, for instance, it classifies you among those who are 50 and compares you to what is normal within your age grade. This is why the age of the patient is very, very important and paramount in OCT. So in these parameters, we'll be looking at the average retinal nerve fiber layer thickness, the retinal nerve fiber layer symmetry, the rim area, disc area, average cup to disc ratio, vertical cup to disc ratio, cup volume. So we'll be looking at all these and a whole lot more. The next is, so we want to look at the average retinal nerve fiber layer thickness. So the average thickness in normal eyes is about 100 to 115 micrometers, and then the inferior quadrant, which is the thickest, is measures about 129.15 to 16.87 micrometers. And again, the superior quadrant measures about 135.34 plus or minus 20.40 micrometers, while the nasal quadrant measures about 85.10 plus or minus 26.60 micrometers. So what we're trying to say is that the retinal nerve fiber layer has a level or a measure of thickness. So now you cannot measure this thickness with your ordinary eyes. You can, but the OCT, which is a machine, has the capacity to do this. It can measure what the thickness is and tell us the value. Now there is a range for the superior part of the retinal nerve fiber layer, the inferior part, and every other part. So we can see here that the inferior quadrant, which is always the thickest, this is why we say that every time there is a loss in nerve fiber layer due to glaucoma, is going to affect first the inferior part. So this is the thickness. So your machine will give you the parameters and then also give you the range at which the thickness ought to be. So when we see a misnomer, in other words, when we see a thickness that is different from what we are seeing here, we want to question why it is so. So having said that, let us look at the next point, which is the average retinal nerve fiber layer thickness. And again, we are also saying that the temporal quadrant measures about 67.19 plus or minus 13.25 micrometers, and the retinal nerve fiber layer thickness declines with age. So as the patient begins to age, it is expected that the nerve fiber layer will reduce as the patient ages. Also, some studies report that females also have slightly higher values than men, and also there are variations among ethnic groups. So when we look at the retinal nerve fiber layer thickness, there is what we call color codings, which helps us to give us a quick overview on what we are dealing with. A green color coding signifies normal limits. Now we are looking at the retinal nerve fiber layer. So when we see a green color coding, it signifies that whatever we are looking at is within the normal limits. If we see a yellow coding, it shows that the what we are looking at is in the borderline. So it gives us concern to query more. while a red color coding signifies outside normal limits. A gray color typically indicates that normative data are not available or applicable for that region or for the patient. What we mean is this, that for instance, there are certain parameters that we cannot, because this test is a comparative test. There are some data that are not readily available for that patient. So the machine, we call it as gray. For instance, the patient might have a big disc, a large disc. So because of the range is not in the machine, what the machine does is that it will give you a gray color, signifying that what you are looking at, there is nothing to compare it with already available information. That is what a gray color signifies. While a white color indicates that the measured thickness is above the 95th percentile of the normative data. So for instance, if you have a case of maybe an edema now, or you might likely see a white color coding showing you that a white color coding does not utterly mean that it is wrong or the data is bad. It just shows you that, oh, this is healthy, or probably there is a swelling or an increased thickness in that area. So whenever we see a white color coding, two things comes to mind: an increased thickness or a normal data. Now, the symmetry, it refers to the degree of similarity in thickness profiles between a person's right eye and left eye. Now, every time we are looking at the two eyes, we want to note what the symmetry is, because any organ that is two in the body, there should be a level of symmetry within them. So we want to be able to ensure that the symmetry of the right eye and the left are the same. So differences should be between 9 to 12 micrometers, and it ranges from 76 to 95%. So when we begin to see symmetries of 30%, 40, 50, 60, it shows that something is wrong. Also, the rim area is very, very important. Remember, we said earlier in part 1 and part 2 that neuroretinal rim is more indicative of glaucoma than a cupped disc. So the neuroretinal rim is the nerve fiber layer before it exits the eyes, and a thinning of the neuroretinal rim is indicative of glaucoma. We said this in part 1 and part 2. And also, the rim area is calculated by subtracting the cup area from the total disc area. A large disc will have a larger rim area. So when we see a large disc, it is expected that we also see a large rim area. The mean neuroretinal rim area in normal subjects has been measured at roughly 1.40 to 2.09 millimeter square. So this is the mean neuroretinal rim. Now this is a table showing these parameters and what we are expecting. So you can see here that the cup to disc ratio, we expect a cup to disc ratio of 0.51 plus or minus 0.14. We call this within normal range. But for Africans, if we see a cup to disc ratio of 0.5, we want to question why it is so, because the normal for Africans is 0.1 to 0.4. Also, you see the disc area in millimeter square. This is the range, 1.91 plus or minus 0.32. Also, the rim area, the mean is 1.32 plus or minus 0.21, and then the cup volume, it is 0.14 plus or minus 0.11. Also, the horizontal cup to disc ratio and the vertical cup to disc ratio. But remember that in glaucoma analysis, we are more interested in the vertical cup to disc ratio than in the horizontal cup to disc ratio. Now, this is an image of an OCT result with optic nerve head parameters. So we can see in this patient, this case, this is the retinal nerve fiber layer thickness map. Now, this is the optic nerve head parameters we are talking about all this while. So you can see the difference in color. There is a green color here, there is red here, there is red here, there is gray here, and there are red all through here. So this green here, which is 75 micromillimeters, it shows that for the right eye, the average retinal nerve fiber layer thickness is fine. But when we look at the left eye, it is 65, and then the color is red. So it shows us that there is something going on there. But when we look at the retinal nerve fiber layer symmetry, it is 84%, and this is fine. But when we look at the rim area, you see that the rim area is not within the normal limits. There is something wrong there. If you look at the disc area, now for the disc area, you find out that the color coding is gray. What this means is that there is no data to be compared with what we see in the patient. For instance, just like a student who goes to a new school and then there is no class to put the student. He can't be in primary 1, he can't be in primary 2, or even up to primary 6. So he has to be given a different class and a different school uniform per se, in quote. So this is what we see in the disc area. That is why for this patient there is no data to compare with, which has already been inputted in the machine. So that is why the color appears gray. And we can see the average cup to disc ratio, vertical, cup volume, they all appear red. Now, the OCT remains the gold standard in optic nerve head and retinal nerve fiber layer analyzers. So other forms of assessment includes confocal scanning laser ophthalmoscopy, scanning laser polarimetry. Now we want to look at the optic nerve head stroke retinal nerve fiber guided progression analysis. Now what we are trying to say in this segment is that there are the Z-Cyrus has the ability to monitor progression or changes in glaucoma over time, because most times what we are doing is that we are comparing a former result to what we have now. So we compare 2-3 results, but this machine has the capacity to compare for us. In other words, it saves data of what has happened before, and then in view of what we are doing now, it has the capacity to show us what actually is going on. Now, with guided progression analysis, Cyrus can perform event analysis and trend analysis of retinal nerve fiber layer thickness and optic nerve head parameters. Event analysis assesses changes from baseline compared to expected variability. If change is outside the range of expected variability, it is identified as a progression. While the trend analysis looks at the rate of change over time, using linear regression to determine the rate of change. So all this is done by the machine, and then it just gives you what you want to see. So also the retinal nerve, now in this aspect, the retinal nerve fiber layer thickness maps provides a color-coded display of retinal nerve fiber layer for 2 baseline exams and 2 most recent exams. So it saves the it has a record of the previous exam that was done before, and then it compares it with what is going on now to give us a guided progression. So this is what a guided progression analysis looks like. So you can see that there are 2 results here in this place, and then all these, I'll be talking about all these shortly so that you understand what we are doing in this page. So the retinal nerve fiber layer thickness change map. So in this map, it demonstrates change in RNFL thickness. Up to 8 exams are automatically registered to baseline for precise point-to-point comparison. Areas of possible decrease are color-coded yellow when first noted, then red when the change is sustained over consecutive visits. So what this machine does is that it tests you for the first time, and then if there are areas of concern, it colors them as yellow. Then on your next visit, when that concern is repeated again, it colors it as red, and then this is presented to the clinician. Now for the retinal nerve fiber layer thickness, the average superior and inferior and average cup to disc ratio values are plotted for each exam. In this example, the graph series will indicate yellow for possible decrease starting with the 4th point, progression to red if a likely decrease, if more than 4 visits are available or the 2 visits displayed are 2 years apart. The rate of change is shown in text. So for the thickness profiles, the values from exams are plotted. Areas of statistically significant change are color-coded orange when first noted and maroon when the change is sustained over consecutive visits. So then there is the retinal nerve fiber layer optic nerve head summary. It summarizes the GPA, that is the guided progressive analysis analyzer, and indicates with a check mark if there is a possible or likely loss of retinal nerve fiber layer. The thickness map progression is best for focal change. The retinal nerve fiber layer thickness map progression is best to identify a focal change, while the thickness profile progression is best for broader a broader focal change, for a generalized change per se. And also the average RNFL thickness progression, average cup to disc ratio progression, is also noted in the summary. Now, finally, let's look at diagnosing glaucoma in high myopes. So I'm just going to introduce this concept. Then in a subsequent series, I'll be spending more time on glaucoma and myopia. But this is just a rough overview on it. Myopia has been considered as a major public health concern. High myopes have a higher risk of developing glaucoma. So research has shown that people who are myopic have the tendency of developing glaucoma rather, 7 times more than the average patient. Now, anatomical changes seen in high myope usually look same as glaucomatous damage. If you watch the part 1 of this series, I talked about one of the challenges of examining an optic nerve head in glaucoma analysis is that people who have myopia, they usually have a myopic disc, a tilted disc, so it's usually difficult assessing their optic nerve head. So these are one of the challenges we have in people who have myopia and glaucoma. These similarities in both conditions make assessment difficult and increases the risk of false positive diagnosis. So let's quickly look at the mechanism of action. High myopia causes structural changes to the optic nerve head and also the peripapillary region due to excessive axial elongation. These morphological changes increases the susceptibility to IOP related stress. Pathologic myopia has been linked to stretching and thinning of the retina and choroidal atrophy, which has the potential to extend to the macula. Changes seen in the macula are referred to as myopic maculopathy, and further complications of high myope includes choroidal neovascularization and retinal detachment. What we are trying to say here is that progressive myopia causes structural changes to the retina, and of them is the optic nerve head. So we are likely going to be seeing some morphological changes when we assess the optic nerve head of a myope, and sometimes it can provide a basis to situation of differentiating, are we looking at a glaucomatous disc or are we looking at a myopic disc. But then what is the challenge of diagnosing? I tag this the dilemma of diagnosing. What are the challenges we see? It is usually a Herculean task differentiating both because of the presence of peripapillary atrophy, optic nerve head changes, and then the IOP is normal. So you see a patient who has an IOP of probably 14 or 15 or 16, but then when you look at the optic nerve head, you begin to see peripapillary atrophy, you see optic nerve head changes, and then you are wondering, am I dealing with a myopic case or am I dealing with an optic nerve head that has changed due to glaucoma? So this is one of the challenges clinicians face in the clinic. Also, the disc appears tilted, elongated, and enlarged. Thirdly, cupping appears shallow with disc surrounded by peripapillary atrophy. Remember we said that peripapillary atrophy is one of the signs we could see in a glaucomatous disc. And also the above mentioned features shrouds the true rim loss, which is a vital marker in glaucoma analysis. So when we see a tilted disc, it is sometimes difficult to pinpoint or isolate the retinal nerve fiber layer. When we see an elongated or enlarged disc, when we see all these things, it makes it difficult for us to be able to look at the neuroretinal rim. And again, there is also a lack of normative data for comparison. Remember that OCT examination is a comparative test. Now, the machine already has inbuilt data for a particular diopter of power. So for people who have high myopia, there is no imputed data to compare them with in the machine. So there is nothing to work with, and this is a challenge in this assessment. But what are the helpful tools? and this will be the final slide. So there are three helpful tools we will look at quickly. The presence of disc hemorrhage. Remember in the part 1 of this video, we said that when we see a disc hemorrhage, and it's usually seen in the inferior-temporal part of the disc, it is highly indicative of glaucoma. So when we see a myopic disc and then presence of a disc hemorrhage, then we are saying that probably it is glaucoma. And also an exposed lamina cribosa could be indicative of glaucoma. And then finally, a consistent structural and functional progression over time. Thank you so much for joining for part 3 of this lecture. Next week we'll begin another series on neuroophthalmics. I hope to see you there.